Hello friends, today we'll be discussing INI CET May 2022 medicine questions. So coming on to the first question, tongue fasciculations are seen in A. GBS, spinal muscular atrophy, Duchenne muscular dystrophy, or if it is D. myasthenia gravis. So first let's see what is a fasciculation. So a motor neuron with its muscle fibers supplied, group of muscle fibers supplied, will contribute a single motor unit. So here what happens is, in some neuron diseases, if the terminal axon is epileptically conducting, excessively firing unnecessarily, this will fire a group of muscle fibers supplied by that neuron. So that will cause contractions of that muscle fibers alone. This will produce a visible clinical sign which is called fasciculations. So if you take Guillain-Barré syndrome, it is just a demyelinating disorder which removes of the myelin and produces a conduction block. So there, since the neural integrity pathways itself is blocked, so here you can't expect fasciculations commonly. Next is spinal muscular atrophy. It is a type of motor neuron disease. In SMA, there is a protein which is responsible for anterior horn cell survival. This is either completely lost or it is decreased in synthesis. Okay, based on the percentage, we classify this into 4 types of SMA. And also, if the anterior horn cell in the spinal cord is affected, it contributes to element weakness. And if the same nucleus, cranial nerve nucleus, if it is affected, then it will contribute to bulbar weakness. Both are possible in spinal muscular atrophy. So in SMA, if you see, the clinical features due to element weakness can be wasting, muscle fasciculations, and this is characteristically called as floppy infant in pediatrics due to that hypotonia, severe hypotonia, and patient will be difficult to hold the neck holding difficulties, and sitting difficulties, standing difficulty, walking difficulties, all will be there. And also due to bulbar involvement, 9th, 10th, 11th as well as 12th nerve weakness will be there. So that will contribute to your tongue muscle wasting and tongue fasciculations. In clinical medicine, they tell for diagnosing motor neuron diseases like ALS, amyotrophic lateral sclerosis, or SMA, fasciculations is a must clinical sign to be observed. Okay, so coming back to our questions, fasciculations is common in SMA, and it is not possible in myasthenia as well as Duchenne muscular dystrophy because they are related to muscle disorder. There is nothing to do with some irregularity in conduction of a nerve fiber. Okay, so SMA becomes the good option. Chronic hepatitis B serology they have asked, and they are given the options as hepatitis S antigen, anti-hepatitis HBs AG, and anti-HBC IgG, as well as HBV DNA. So let's see this. First, HBs AG. HBs AG is usually if it will be produced in excess in case of hepatitis B infection. So its positivity always means it is present, infection is present, and so only this much HBs is produced, so only it is used in screening of hepatitis B. It can be negative if the patient has occult HPV infection. Next is so HBs AG must be positive in chronic hepatitis B. Next, anti-HBs AG. It is a protective antibody which is produced. Usually anti-HBs AG forms only when HBs AG dips down. So in a case of chronic hepatitis, this can't happen because HBs AG hasn't dipped down still. Next, so it is positive in vaccinated individual. By definition, chronic hepatitis B means HBs AG should be positive at least for 6 months, more than 6 months, and HBe AG should be positive at least for more than 3 months. Then we call it as chronic hepatitis B. Since HBe AG is not at all given in the question, we are going to think in this process. So let's see, club all the findings we have seen till now. First is, are HBsAg, which is going to be positive throughout the course of the chronic hepatitis B. And if you see anti-HBC IG, okay, immunoglobulins, IgM will be increased in the acute phase, and as the disease progresses to chronic phase, IgG will be elevated. So total will be always be elevated. Total composed of IgG and IgM. IgG will be always elevated. Next is our anti-HBsAg, which is never going to be present itself in this patient. Next, HBV DNA, which will be elevated in the acute phase, and it will be wavering. Okay, waxing and waning course will be there depending on the relapse or remission. A combination of options, we can choose HBsAg must be positive, anti-HBsAg should be negative, and HBV DNA must be positive, and the other anti-HBC IgG will be positive. Age-defining tumors includes all except cervical carcinoma, melanoma, NHL, as well as Kaposi sarcoma. So except they have asked. So age-defining illness is always a hot topic which is asked continuously. So let's remember how to remember all the age-defining illness at a stretch. Okay. Yes. So HIV, as you know, it's a state of immunosuppression. All opportunistic infections will be coming. First, most common will be your tuberculosis. Next, among fungi, if you see, there are 3 C's. First is this fungi, which causes diffuse meningitis as well as disseminated infection in the skin. This is nothing but cryptococcosis. Next is this fungi, which causes involvement whitish mucosal patches over the esophagus as well as the stomach, as well as it can form the same patches over the lungs also, causing systemic candidiasis. It is not oral thrush alone. Okay, it should involve the esophagus as well as stomach. Then only it's called systemic candidiasis. Then only it can become age-defining illness. Next is the next C, which is found in the valley regions, desert valley regions, and also the patient will be having a diffuse pulmonary involvement as well as severe joint pain. Okay, the joint pain is similar to our rheumatic fever joint pains. So it's also called desert valley rheumatism. So this is nothing but coccidiomycosis. So 3 C's: cryptococcosis, coccidiomycosis, candidiasis. All 3 C's, drug of choice is the same drug, fluconazole. Okay, yes. Next is the one more fungi, which is histoplasmosis, which is found in the soil. The spores are inhaled and causes involvement of the lungs as well as skin. Mainly the involvement of bone marrow causing pancytopenia, granulomatous infiltration resembling tuberculosis. Okay, yes. So these are the fungi in the age-defining illness. Next, we'll see virus which are involved in age-defining illness. 3-4 viruses you should be remembering. First is herpes, which is causing labialis as well as involvement of GIT. Next is the HHV8, human herpes virus 8, which involves the endothelial cells of the blood vessels, causing tumor in the blood vessel, which is called Kaposi sarcoma. Next is CMV, which can involve the colon as well as retina, causing CMV colitis as well as CMV retinitis. These also come under age-defining illness. Next, parasites. Among the parasites, first is this spread from the cats, contaminated cyst. This comes and forms cyst-occupying, space-occupying lesions in the brain, forming granulomas in the brain, which is nothing but toxoplasmosis. Then next one is this parasite, which are responsible for chronic diarrhea in HIV patients. 3 should be remembering those cryptosporidiosis, Isospora belli, all those things, and also giardiasis. Next is your ping pong balls, fungi, which forms cyst in the lungs, pneumocystis, pneumonia. Yes, cancers in HIV. Main cancers are invasive cervical cancer and Burkitt's lymphoma, non-Hodgkin's lymphoma. So all 3 were given as the options, and also Kaposi sarcoma was given as the option. Exception is melanoma. Transcutaneous electrical nerve stimulation works on the principle of. So TENS, this is one of the strategy to combat chronic pain syndromes involving any visceral organs. So what actually happens in pain syndromes is any pain due to stimulation of, as you know, A delta or C fibers. So this will be stimulating the projection neurons which will go to the sensory cortex and which will be perceived as pain. So what we are going to do here in these TENS and this acupuncture, all those techniques are, we are going to stimulate our touch fibers, which are the A beta fibers. When these fibers are stimulated, there are some inhibitory neurons in the spinal cord which is stimulated. This inhibitory neurons inhibits the conduction of this painful stimuli to the brain. So brain doesn't perceive pain now. Okay, and also it transmits so many signals directly to the tracts as well as to the brain also to suppress this pain. So it works on this principle is called gating. So 10 ECG was given, and I don't know whether BP was mentioned or not, and they just asked first drug to be given in this condition. So A options where there no mention about any vagal maneuvers. They just told first option to be adenosine, and next option, one of the options to be beta blockers and calcium channel blockers and DC cardioversion. So let's decode this ECG first. So if you see this ECG, how to approach a tachycardia? First, calculation of heart rate, which is nothing but the distance between two big RR intervals. So if you see the RR interval distance, if it is less than 3 large boxes, then it is tachycardia. So here if you see, it is less than 2 boxes. So it is obviously tachycardia. Next, you are going to see the Qrs complex, whether it's narrow or wide. How to see? Now you should check the 3 small boxes of the Qrs complex. If it is less than 3 small boxes as given in this picture, then it is narrow Qrs. Next, rhythm. How are you going to check the rhythm? Compare distance between any two RR intervals. Here if you see one RR and other RR, it's going to be same. So it is a regular rhythm, narrow QRS tachycardia. So are you going to approach then? Next, what are you going to see is whether the ECG has P waves or not. Obviously no P waves are visible here, only T waves are visible. So that means the pathology is in AV node. It can be a junctional tachycardia or any PSVT. So if it is this thing, how are you going to manage this? So the pathology is at the AV nodal junction. It is only firing excessively up as well as down. So this so to suppress the AV node, what and all procedures you can do? First is the carotid sinus massage and vagal maneuvers like Valsalva maneuvers, carotid sinus massage, all these can be tried. These are the initial maneuvers to be tried. Next, among pharmacological management, initial management will be to see the BP. If the patient is hemodynamically stable, then your obvious choice will be IV adenosine. So if there is some contraindication for adenosine like COPD or some many contraindication exists, then you go for beta blockers. Then calcium channel blockers, I say. So that if they ask treatment of choice, it is nothing but to ablate that aberrant AV node. So radio frequency ablation, treatment of choice is that. But since they ask first thing to be done, obviously if we take it as a hemodynamically stable patient, it is IV. Yeah, drug, ATT drug, which is activated by peroxidase, catalase peroxidase system, and it inhibits mycolic acid synthesis. What is the drug? They have asked. So the answer to this is nothing but isoniazid acid, which 2 genes you would have remembered with respect to resistance of isoniazid acid, which is nothing but CAT-G, which is catalase peroxidase, which produces catalase peroxidase, which activates this isoniazid acid. And INHA, this gene it acts and it inhibits mycolic acid synthesis. So obviously this answer is isoniazid acid. A HIV positive mother who has been on ART is about to deliver. So what are you going to do? Options are A, breastfeed the baby plus nevirapine prophylaxis to the child if the baby is HIV positive, formula feed the baby and nevirapine prophylaxis if the baby is HIV positive, and C, formula feed and nevirapine prophylaxis to be given to the child irrespective of HIV status. D, formula feed the baby plus testing at 0 weeks and 6 weeks and no need of nevirapine prophylaxis at this time. So how to approach this? See, PPT-CT, which is prevention of parent to child transmission of HIV, is very important. Why questions are most focused on these areas? Because if you see a patient who is HIV positive, the chances of her spreading it to the child is 30 to 45% if the patient has not received any treatment. But if you have given proper ART treatment for this patient, and if you have given prophylaxis, means this percentage of 30 to 40 will reduce by 1 to 2%. So this is why questions are more targeted in this area. So let's focus on the NACO guidelines 2022, which is released recently. So what they told was the 4-pronged strategy in this patient. First is primary prevention, preventing the girl from getting HIV by this ARCH program, reproductive and sexual health program. And if the girl has got HIV, next what you should do is you should counsel the girl so that to prevent unintended pregnancy. Before pregnancy, her viral load must be suppressed. Okay, this you should ensure. Then only you should allow the patient to get pregnant. Or you have not done this, the patient has got pregnant. So at that time, what you are going to do? Here comes the role of management. Okay, how to prevent the child from getting HIV. Or if the child also has got HIV, what are you going to manage? These are the 4-pronged strategy in NACO 2022. So according to this, what they tell is, if it is the child is a low risk infant, meaning if the mother's viral load has been suppressed by proper ART treatment to the mother, then for this baby, syrup nevirapine to be given till 6 weeks of age, irrespective of HIV status. Okay, and if nevirapine is contraindicated, you can go for zidovudine. And next thing is, if the patient is a high risk infant, like the patient mother got HIV positive after 32 weeks, the patient has not started ART, and the viral load is not suppressed, all these conditions are high risk transmission. So there you should go for dual prophylaxis, meaning combining both nevirapine as well as zidovudine, and it should be given for 6 weeks if the patient is replacement feeding is given to the patient, or if the patient is breastfed, meaning greater chance of spreading. So you should be giving for 12 weeks dual prophylaxis. Okay, so thus if a low risk infant, just syrup nevirapine or zidovudine if nevirapine is contraindicated. Then if it is a high risk infant, dual ARV prophylaxis till 6 weeks if it is replacement feeding, till 12 weeks if it is exclusive breastfeeding. Okay, yes. So answer to this question is option C, formula feeding plus nevirapine irrespective of HIV status. Even if HIV negative, you should give for 6 weeks. Yes. Next question. The clotting factor which decreases in pregnancy. As we know, pregnancy is a hypercoagulable state. All clotting factors increase. Only clotting factor 11 decreases in pregnancy. So an unknown poisoning patient comes with the complaints of nausea, vomiting, seizures, and sweating, diaphoresis, and skeletal muscle spasms, tachycardia. Okay, what are you going to do first for this patient? Beta blocker, IV atropine, and flumazenil, calcium gluconate. What are you going to give for this patient? So it's nothing but obvious, it is OPC poisoning. So the effects of OPC will be divided on the receptor it acts. Like muscarinic effects acting on the heart, it will cause bradycardia as well as hypotension. And acting on lungs, it will cause bronchoria, increased secretions, and secretions of GAT causing diarrhea, increased peristalsis also, and also micturition, increased frequency of micturition will be happening due to stimulation of bladder muscles. So all these are muscarinic side effects. Lacrimation, salivation also is. Next, nicotinic will be stimulation of the skeletal muscles leading to skeletal muscle spasms, as well as tachycardia due to stimulation of ganglions. Okay, so to stimulate the sympathetic ganglion, there will be tachycardia in these patients. Anything can happen. Less than 30 minutes, all these you can expect. And central nervous system action, muscarinic actions will be this of convulsions, coma, hallucinations, all those things can happen. So management in this patient will be First will be giving activated charcoal. If the patient is altered, we'll be securing this A, B, C, all those things will be managed. Then you'll be starting with atropinization. IV atropine 2 to 5 mg will be given every 10 to 15 minutes until atropinization happens. So after atropinization, then we'll be maintenance dose of atropine should be started at a dose of 20% of the dose required for atropinization. Then this will be tapered off in 5 to 10 days. Okay, and paradoxum if the patient has presented early. So all these you can give. So in this patient, if you see, obviously the answer will be IV atropine. Next, specific feature of muscarinic poisoning: A, diuresis; B, bradycardia; C, skeletal muscle spasms. So as we saw, skeletal muscle spasms can be due to stimulation of nicotinic receptor, not muscarinic. And also bradycardia is due to stimulation of muscarinic, and tachycardia is due to stimulation of nicotinic. Bradycardia can be kept as the answer for this question. And also diuresis means increased production of urine, might be B, bradycardia. Okay, thanks for watching the video. We'll be uploading soon the next set of questions.